Okay, can you guys hear me okay?
Yeah.
Yes,
Okay.
ma'am.
Yeah.
Okay, so let's talk about the neuro assessment. So you guys know this is extremely important. And now that we've kind of moved through neuro a little bit, you can see how important the neuro assessment is, because we're always going to go back to that. Majority, and you guys will learn a little bit more about this when Mrs. Phillips talks about some of the other central nervous system things in the brain, and then peripheral nervous system, which is like Guillain-Barré, myasthenia gravis. A lot of these things like Alzheimer's and Parkinson's and Guillain-Barré, a lot of them, there's no test that we specifically do that says, yep, this is migraines. Yep, this is ALS. Yep, this is Alzheimer's. These are all clinical diagnoses. We put together the picture from our assessments and the way the patient's behaving. So this is why the assessment is so important in neuro, because it's very different than like a heart failure patient, where maybe we can do the BNP and we can see that the BNP is elevated, and we are indicating that the heart's struggling. So, so your assessment is super, super important. I promise you, this exam will be neuro assessment heavy. Okay. So we think about the neuro assessment, who can give us the best information? Well, of course, the patient, if they're able to tell us about their symptoms and kind of what has led to the situation. But if not, we need to talk to the person that spends the most time with the patient, or the person that was at the scene, because this could be something like maybe like a Parkinson's or an Alzheimer's, and the patient slowly starting to change or get confused or something like that. Or this could have been a massive trauma where they were fine 1 second and then immediately they were, their condition changed. So it's really important to say, like, how did this happen? Did the person pass out first and then get in the car accident? Or did the person get in the car accident and then lose consciousness, right? And then just making sure, we talk to the nurse or the provider at the scene, who was the first person at the scene, what happened, what led to the event. I'm always like, okay, what came first, the chicken or the egg? Did they have a seizure and then get in a car accident? And now they have this, spinal cord injury, but we have to treat the seizures too. Or were they in this car accident, have a spinal cord injury, have a traumatic brain injury, and now we're having seizure activity, right? What are their symptoms? How long have they been lasting? Any concerns that the person or the family has? Any complaints? And then also family history. We talk about like autoimmune disorders like myasthenia gravis or Guillain-Barré. Do they have a family history of autoimmune disorders? What are some of those things that may contribute to this patient's complication? So we're going to go back to kindergarten and teach Jill how to number again, because Jill did not number these in the correct order. Okay. So if you guys remember from my PowerPoint, I'm like level of consciousness first. I have that highlighted in red. It's so important, right? So level of consciousness is the first change that you're going to see with your neuro assessment. So that's number 1. Then we talk about motor function, number 2, pupils, number 3, respiratory, number 4, and then vital signs, number 5. So then when I separate these out, I'm like level of consciousness, number 1, motor, number 2, pupils, number 3, and then I skipped 4. I went to 5 for respiratory and 6 for vital signs. So scratch those out if you use the concept map, or if you rewrite it yourself and just number appropriately, because I obviously don't know how to. So level of consciousness first. So I've talked about a couple exaggerated situations that I've been a part of, and even just the slightest change in level of consciousness indicates a repeat CT scan, indicates that we need to figure out what's going on. Okay. So level of consciousness, we actually use verbal stimuli first. Like, do they just open their eyes spontaneously? If you walk into the room and say, Mr. Smith, please open your eyes, are they able to do so? Okay. Do you have to talk soft? Do you have to talk loud? If you guys walk through SIC, what do you hear? A lot of people yelling, right? A lot of the nurses are like, open your eyes, right? And you hear people yelling all the time. And if you're not familiar with the fact that that's what they're trying to do is stimulate the patient, it can be overwhelming, right? If you're a family member. If they do not respond spontaneously or to verbal stimuli, then we have to get to tactile stimuli, right? So now it's touch, right? So we're just going to touch them, touch their arm, some kind of light touch. If they don't respond to light touch with verbal, then we're going to go ahead to do a little bit more vigorous shaking to see if we can get them stimulated. If we cannot get them stimulated spontaneously, verbally, or by tactile, then we've got to implement noxious stimuli. So remember, we have central, sternal rub, trapezius pinch, or you could do peripheral, which would mean you can pinch the inner part of the arms. You can do deep nail bed pressure on the feet or the hands. But remember, if you're going to do a peripheral stimuli, you need to do it in all four extremities, because we need to see if the patient was responding, or maybe the patient's mentally intact, but they have a history of a stroke on the left side of the body. So let's say you do deep nail bed pressure on the left hand. If that patient has a stroke, they can't respond, but maybe they are able to respond and withdraw to pain, and they have enough mentation to do that. Okay, so just remember that point. If we don't pick up a change in level of consciousness, maybe because we're unable to, maybe we have the patient on a paralytic or a sedative, and we have them oversedated or they're paralyzed, they're unable to respond. Okay, so then we say, okay, do we need to try to get into a motor assessment? Because there's something that we can do a motor assessment that we can pick up on. So we're looking to see if they voluntarily move or involuntarily move. Okay, and then I pulled this out of the book for you. So 0 out of 5 is no movement, 1 out of 5 is trace, 2 out of 5 is movement with no gravity. So that means that you hold up and you alleviate gravity, but they're still able to move the extremity. And then 3 out of 5 is movement with gravity. So this means they move up against gravity. So you're able to lift your arm up off the bed, lift your leg up off the bed, right? 4 out of 5 movement with resistance. And then 5 out of 5 active movement. Is the movement spastic or rigid, right? Is it like uncontrolled, very spastic type rigid? We'll talk about that a little bit more when we talk about some of the central nervous system, like Parkinson's and Huntington's. Are they hypertonic, meaning a lot of tonicity? Or is it hypo, where we have a little bit more of a weakened appearance of the muscle movement? And then we go to pupils. Okay, so if we don't see a change in motor function, or we can't assess the motor function, maybe because they're on a paralytic, then pupils. So if your patient is paralyzed because either they're paralyzed, or we've paralyzed them because of our neuromuscular blocking agents, then we have to look at the pupils and say, okay, this is the first and the only thing that we could probably do initially to assess a change in mentation, right? So we can't assess level of consciousness if they're paralyzed. We can't assess motor strength if they're paralyzed. So how would we recognize a change? Well, that would be change in pupils. Okay. So we always talk about PERLA, pupils equal reactive to light and accommodation. If your patient is sedated or paralyzed, are they going to be able to accommodate? Probably not. Please don't chart that. So we're really looking to see if pupils are equal reactive to light. Okay. And are they brisk? Are they sluggish? Are they even? Are they fixed, dilated? If they're pinpoint pupils, I think maybe we've given them a lot of pain medication and we've oversedated them. If they're fixed and dilated, that's a bad neurological sign. Bad neurological sign. I think brain death. Okay. And then we go to number 4, aka 5. And then we go to respiratory. Okay, so are we seeing change in respiratory pattern? Well, this is really hard to assess for when somebody's already in the ICU and they're on a ventilator, because can we see Kussmaul's respirations or Shane Stokes respirations or apnoistic? Well, no, if they're on assist control, the ventilator is going to do all the work for them. So respiratory, I think a lot about the apnea test. Remember, we talked about that with brain death criteria. We shut the ventilator off. Does the patient have abnormal breathing, or are they able to initiate a breath? Do we have an altered rate or rhythm of their respiratory status? And then 5, aka 6, are vital signs. Okay, so the 5th neurological assessment or change that we have to observe for is vital signs. And this is a late sign. Vital signs, this is a late sign. So we should be thinking this is a poor prognosis if we're seeing major significant changes in the vital signs. So you'll see it's opposite of shock. So remember what shock, you'll see the systolic blood pressure drop. You'll see you'll see a narrowed pulse pressure. So they kind of come together, the systolic drops. The patient will become tachycardic because beta 1 kicks in and is trying to compensate. But in these patients that have that have an increased ICP or neurological deficit in the brain, we're going to see a change in vital signs. So systolic blood pressure is going to go up, heart rate's going to go down, respiratory rate's going to go down, and we're going to have abnormal respirations, widened pulse pressure. So we're going to see that systolic go up and the diastolic go down. So widened pulse pressure, and we call this Cushing's, and this is Cushing's triad. Okay, so make sure not to get confused with Cushing's phenomenon. Okay, So if we continue, what are we thinking about if we're thinking about our neuro assessment? Well, why are we doing this for somebody that has an elevated ICP, okay, or has a traumatic brain injury? Well, we're looking to see if the brain is swelling. Are we perfusing the brain well enough? Or is the patient approaching brain death? Okay, and Mrs. Phillips will talk about this a little bit more when she teaches organ transplantation, but one of the number one organ transplant situations is brain death. Patients come in young, we say male because, you know, in these trauma situations, they typically occur more male than female. So if a young 20-some-year-old that fell off a roof or car accident, or you guys were talking in the about in the ICU, everybody was drinking, you know, so maybe somebody, you know, was alcohol intoxicated, fell, hit their head, but did not enter anything else in their body. They are, if their brain shows inactivity or incompatibility with life, they are actually usually the perfect organ donor because everything else in their body is good. So we have to think about brain death and organ donation and transplantation. So if we're looking at brain death, how do we assess for brain death or the fact that the brain may be intact? So we do the corneal reflex test. That's where we take the wisp of cotton or a 2x2 or something and wisp it across the cornea. And what would normally happen if you did that to your eye and you're awake and alert and your brain is intact, you'd blink, right? That's a protective reflex. So when we're testing brain death, we're testing our normal protective reflexes. Okay, so if we are missing that, then we see that that reflex is absent. That's a bad sign. We also do that test as a reminder to make sure that, you know, if you have somebody that's chemically paralyzed, we've induced their paralyzed state, we need to make sure that we lubricate the eyes either by like almost like a Vaseline gel or eye drops, because every time you blink, you actually lubricate your eyes. But if you're not blinking because you're paralyzed, you can actually cause damage to the cornea and cause corneal ulceration. So we need to make sure we lubricate the eyes. Do we have a cough or a gag? Those are protective reflexes. We gag so we don't aspirate. We cough so we don't aspirate. So we assess, do they have a gag or a cough? We do the apnea test, right? So we shut the ventilator off. And there's a whole protocol. If you're in the ICU, you can look at it, especially in SIC. That's where we do majority of our brain death testing. But, you know, they give the patient hyperoxygenate them. They shut the ventilator off for so many minutes and they wait to see if the client initiates a breath. Okay, so we could do the apnea test, which is if you, you know, hold your breath for so long. This is why people can't hold their breath for long periods of time, because your normal reflex is to initiate that buildup of the CO2, initiate that inspiratory effort. Okay, we have our oculocephalics, right? That's the doll's eyes test, and then you have your oculovestibular, which is the caloric test. Okay. So oculocephalics is where we're looking at the doll's eye. Okay, this is when we're turning the head back and forth. We're looking to see if the eyes move. So if you turn your head in one direction and your eyes move in the opposite direction, that's normal. And that means that the reflex is intact. Okay. If you move your head in one direction and one eye goes, but the other stays midline with the head, then we say that's an abnormal test and there's likely some damage to the brainstem. If you move your head and the eyes stay midline with the head, right? They stay in the direction that the head is turned, then that means that the reflex is absent and there's brain damage, that the brain, we have brain death. Okay. Don't forget, I put a little comment here, check the C-spine first, right? That's a priority for the nurse. And remember, after we've studied cervical, like spinal cord injuries, right? If you turn your head one direction or the other, or you, anytime somebody has a traumatic incident where you have a traumatic brain injury, we assume that there's a spinal cord injury until proven otherwise, right? So we should be whipping around this patient's head if we're concerned that there's a spinal cord injury, right? Because what if the test actually is good? Right? We're not in the patient's not brain dead. We don't want to cause damage to that spinal cord. We also have the oculovestibular. This is the caloric test. Okay. And this is where we actually have the patient laying on their back. Eyes are midline. You have to hold the eyes open when you do this test. Both tests, usually you have to hold the eye open, and you're going to inject the ear with ice water. Okay. And it's like 30 to 20 to 100 or 30 to 100 milliliters of ice water you inject into the ear. And if the eye is nystagmus, right, that quick, swift movement and nystagmus towards the injected ear, that is a good sign. That means that it's normal and the reflex is intact. If one eye moves or one eye goes the other direction, one stays midline, but the eye has nystagmus and moves, one of them does, that means that it's abnormal. There's likely some brain damage, but there's not brain death yet. If the eyes do not move and they stay midline and they do not shift towards the injected ear or move in any direction at all, then that means that the reflex is absent and there's brain death. Okay. And then just a reminder, the TM, which is the tympanic membrane, it must be intact. The tympanic it must be intact. Okay. So what are our goals if we have patients that are, have a traumatic brain injury, have a neurological injury? Well, airway is important. Okay. If you have a traumatic brain injury, there's injury to the brainstem. Remember, we lose our ability, our drive to breathe. So you have to be thinking airway. So airway, elevate the head of the bed. Do we have to suction? Do we have to put them on a ventilator? Right. Circulation. So we have to think about perfusion. And remember, we talked about, so we have to think about this with the traumatic brain injury. You're going to have changes in your vital signs, but we also thought about this with spinal cord injuries, right? Remember, we talked about that autonomic nervous system. And if you have a high spinal cord injury, you can go into neurogenic shocks. We need to think about circulation. Are we perfusing our brain? Are we perfusing our kidneys, our organs, our lungs, our heart, right? We have to think about circulation. If we are not, if our MAP is low, our mean arterial pressure is low, and we're not perfusing, well, what do? You guys already know that. You guys studied hemodynamics already. Do we give an inotropic agent? Do we give a vasoactive agent, right? Do we give a vasopressor like norepinephrine or neosynephrine or epinephrine? Do we have to dilate? Do we have a high pressure? We have to dilate, right? So we have to think about how can we perfuse our organs better. Don't forget to prevent DVTs. If you're talking about a traumatic brain injury, spinal cord injury, these patients are not moving. They're not getting up and walking around, right? So DVT prevention, preventing skin breakdown, preventing stress ulcers, making sure we're doing range of motion, prevent a decrease in range of motion, and preventing foot drops. So don't forget to make sure they have the tennis shoes on or the Prafo boots. We have to monitor temperature. This is a priority. Remember, we don't want the temperature up and down, up and down, up and down, right? And if we have damage to the hypothalamus, we're not unable to regulate our temperature very well. So we want to prevent shivering because that decreases or that increases the metabolic demands. If the temperature's up and then down and then up and then down, that increases the metabolic demand. So we like the patients to be cool and euthermic. We want to keep them at kind of a steady level so that they're not bing, 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 and they're trying to warm themselves up and then cool themselves down, then warm themselves up. And shivering also increases the metabolic demand. Okay. So if we think about our ICP, right? If we think about our ICP, we want our ICP less than 15. We want our MAP greater than 70. If the ICP changes and goes up, early signs of an elevated ICP is going to be a change in level of consciousness. I've said this over and over and over again. Late signs of an ICP, we're going to see change in respirations and change in vital sign. Okay. Don't forget our cerebral perfusion pressure. We want it greater than 70. We'll accept it if it's 50 to 70, but less than 50 is bad. So if your cerebral perfusion pressure is low, we have to fix it. Well, how do you get the cerebral perfusion pressure? Well, you take your ICP, your MAP minus your ICP. So if you have a MAP of 70 and ICP of 15, your cerebral perfusion pressure is 55. So it's okay, not great, but we need to make sure that none of those numbers change. That would make your cerebral perfusion pressure worse. Okay. So let's say you're less than 50. That's bad, right? How do we fix the cerebral perfusion pressure? Well, you have to fix the problem. So if the problem's the MAP and your MAP is low, then what are we going to do to fix the MAP? We'll give vasopressors. Do we need to give fluids? Do we need to give inotropes to bring up that mean arterial pressure? If the ICP is high, your MAP's okay, but your ICP is high, then we need to fix the ICP. So do they have a ventriculostomy? Can we drain it? Do we need to give osmotic diuretics? And then I put some information here, see below, ways to decrease the ICP. Okay, so we can look at other ways to decrease the ICP. So if we're going to decrease the ICP, body in good alignment, we start least invasive and go to most invasive. I'm not going to run in there with mannitol if my patient's curled up like a ball, right? So body in good alignment. We want to decrease the stimulation, decrease the body temperature, decrease the light. We have to be super careful with fluid management. Sometimes we have to give fluid or we give colloids, but we don't want to overhydrate or give them too much because remember, sodium is a big component to the brain. So we don't want the sodium to be too low. We don't want the sodium to be high. Sometimes we're giving medications that like mannitol can make your sodium low. We're giving 3% sometimes, which can make your sodium high. And thinking about that sodium level, that can contribute to how much fluid you hold off and how much hold on to, or how much fluid you release. And it also contributes to how much swelling you have in the brain. We want to make sure we avoid hip flexion. We want to make sure the knees aren't bent. The neck shouldn't be flexed. Okay. It shouldn't be turned like this. It shouldn't be flexed forward. We want to avoid abdominal distension. Make sure you watch your PEEP. So these patients that are on a ventilator are already receiving positive pressure ventilation, right? That's what our ventilators are, positive pressure ventilation. But if you have somebody that goes into ARDS, what do? We increase the PEEP, right? Do we want to increase the PEEP of somebody that has a high ICP? The higher the intrathoracic pressure, the less venous return we have. Okay, so if I have a high intrathoracic pressure, remember this is hemodynamics, I have a decreased venous return. Well, if I can't drain the blood back into the right side of the heart because my pressure is too high in my chest, where's that blood going to go? Well, it's going to go everywhere else in the body, and it's going to fill back up into the brain. So anything draining out of the cranial vault is not going to be able to filter back. So that increases the ICP. So we have to be careful about PEEP. It can increase the ICP. We need to make sure we get rid of our CO2. So we got to hyperventilate the patient. We've got to drain our cerebral spinal fluid. So if they have a ventriculostomy, can we drain it? Can we open it up and remove some of the cerebral spinal fluid off the brain? Can we give mannitol? That's an osmotic diuretic that's going to dehydrate the cells and pull some of the fluid off the brain. Do we sedate them? Remember, stimulation can increase their ICP. It increases the stimulation. So do we need to sedate them to calm them down? If that's not enough, do we need to paralyze them, right? And then we talked about steroids. If we have a lot of swelling, steroids are anti-inflammatory. So do the steroids help? Okay. So all things we need to think about to decrease the ICP. If your patient's posturing, that's a bad neurological sign. So I have that in red here. Decorticate, they bring their arms, their knees up to the core of their body. Usually it means a midbrain injury. And decerebrate means that there is an injury to the brainstem. So worse, right? So poor neurological sign. Okay. So any questions on the neuro assessment? The down and dirty of the neuro assessment before I move on to traumatic brain injury.
Why don't they want their knees to be bent? Because they're just trying to like increase perfusion.
So if you bend your knees, it actually increases your intra-abdominal pressure and it changes your venous return. So the cardiac output is unable to be perfused to the extremity very well. If you bend your knees, you're bending your hips. So you're flexing and you're changing your venous return. It's hard to imagine that something like that would be so significant to a neuro patient, but it's unbelievable how big of a difference it makes.
I was just thinking about like if you pull your knee up and how your hips move too. So I was like, okay, that makes sense.
Yeah, for sure. For spinal cord injuries, we think about that a lot, but for traumatic brain injuries, we think a lot about how it increases the intra-abdominal pressure. Like if it's been a long time since I've been able to pull my knees all the way up to my chest or sit like in a ball, but my kids do it all the time. And if you pull your knees up or you flex your hips, it actually changes your thoracic and intra-abdominal pressure.
Okay, thank you.
Sure. Any other questions? Okay, so let's go ahead and move on to traumatic brain injury. So this is broken up into 2 slides. I did go ahead and post all of the concept maps for neuro. I usually don't do that because I think it's so important to hear the lecture first, but some of them kind of overlap and I thought it might be helpful if you guys are trying to study ahead of time to get caught up for exam 4. So traumatic brain injury. Okay, so now we're thinking, and this crosses over with the neuro assessment very nicely. So causes of traumatic brain injury, number 1 cause is a fall. We think of that, I have up there in blue up here, acceleration, deceleration, force. So like coup, counter coup, bing, bing. So fall, they hit their head on their fall. Motor vehicle crash, they hit the dashboard, they hit the steering wheel, they hit the side of the vehicle. Assault, or maybe they were struck by an object. So something like that. Young patients and then elderly patients. So like we see younger patients, remember we talk about like kids falling, like their head is so big, they like topple over and hit their heads, right? So the younger population, like usually less than 20, we see elderly population, because fall is the most common things. We see a lot of elderly patients that fall and end up with traumatic brain injuries. And then males are more common than females. We can have penetrational injuries. So that's where we actually have something that penetrates the skull, or a rotational injury. And if you guys remember, like a boxing injury, where it's the head rotates so fast that the axons are torn and twisted. Okay. So let's remember, primary is the injury itself. So that's the impact of like the coup counter coup. That's the impact against the windshield or the impact against the bat if it was an assault injury, or impact against the floor. The secondary part is the swelling. That's the increase in the ICP, the bleeding, the infection, the ischemia. Now I've got all this pressure in my head from all the swelling, and I have ischemia because the pressure is so high, I can't get the blood up into the brain to perfuse the cells. So traumatic brain injuries can go to, we can start with the skull. So we can have skull fractures, right? It can be something linear. It can be something depressed. We can have an open, which means that the skull, the tissue is open into the brain. And then our most common one, we have this basilar skull fracture. So it's at the base of the skull. I've wrote that numerous times. And we can have the raccoon eyes. If you guys remember that ecchymosis around the eyes, the battle sign is the ecchymosis behind the ear. And a lot of times we have to be concerned, is the dura torn? Well, if the dura is torn, obviously we have higher risk of infection, because now that protective lining around the brain is no longer there, or it's no longer intact. It's there, it's just not intact. So now we can, any type of microbe can get in there. And then we have to think about the cerebral spinal fluid, because once the dura is torn, we can have cerebral spinal fluid leaking. So you can have cerebral spinal fluid out of the ear or the nose. So the nose is rhinorrhea, the ear is otorrhea. Don't forget, we have to catch it for the halo sign. So we can catch it with a 2x2 or 4x4 dripping out of the ear or the nose. And we're looking for that red dot in the middle with the cerebral spinal fluid around it. And sometimes there's a linear red line around the outside. So it looks like a halo. Remember the rules. If you have somebody that has a basilar skull fracture, we want to catch them. We want to catch the fluid leaking, not plug, because if you plug it, then you're actually going to increase the ICP. Okay. And you can have patients that have basilar skull fractures and they're alert and oriented. Okay. So just because we consider this as part of a traumatic brain injury, these patients might have a ton of swelling. They might have ecchymosis around their face, depending on how things have broken. They might have the battle sign behind there. They might have cerebral spinal fluid, but they can be completely alert and oriented. Classic basilar skull fracture is the ecchymosis, and then the battle sign. And then, if they have the dura torn, then we see that cerebral spinal fluid or the halo. Remember, no NG tubes. We're not putting anything up the nose, into the ear if we have somebody that has a dura that's torn. Then we go to concussion. Okay. Remember, a concussion is like you've kind of jolted the brain. We're not bleeding, but you've kind of I don't say you don't tear the nerves, but you kind of injure the nerves. You kind of twinge them a little bit. So this is a mild traumatic brain injury. So number one, the concussion grade number 1, there's no change in level of consciousness, but they have confusion or altered level of consciousness for less than 15 minutes. So they don't lose consciousness, but they can be confused for less than 15 minutes. Grade 2, there's no loss of consciousness, but they have a change in their mentation, or they're confused for greater than 15 minutes. And then grade 3, any change in loss of consciousness. It doesn't matter what their level of confusion is, but anytime they lose consciousness at all, then they're automatically a grade 3. Okay. And then don't forget about like post-concussion syndrome, and just making sure we educate the family or whoever's going home with this patient, because they're typically not admitted, that if they have any change in their neurological signs and symptoms, like headache, a new onset of terrible headache that's worsening, and nausea, vomiting, any kind of seizure activity, any kind of neurological deficit, that they should immediately come back to the emergency room. They can have a contusion. And this is a bruise on the brain. So the contusion is where they hit the brain, and now they have a bleeding into that area. It's not significant bleeding, but it's just like if you bumped your elbow and then a day later you looked and you're like, oh my gosh, I have a bruise there. Okay. It's the same kind of idea. So you have a bruise on the brain. A lot of these patients are admitted to the hospital because we want to make sure that that bleeding doesn't get worse, especially when we look at their risk factors. Like, are they on blood thinners, or are they elderly? Do they have a clotting disorder or something like that? And then we talk about intracranial bleeding. Okay, so this is like below the skull. Okay, we talk about in the cranium, and we have multiple types. You can have epidural, okay, and this is above the dura. So epidural is epi is above the dura. So it's you don't have that Monroe-Kelly hypothesis where the body's able to auto-regulate and change their swelling. So it's above the dura. So that means they're bleeding in between the dura and the skull. So what's the problem? Well, we have to fix it immediately or they will decompensate urgently. So they can fully recover, but they have to get to OR almost immediately. Majority of these patients require surgical intervention where they go in and remove the hematoma or the bleed so they could decrease the ICP. Then you have subdural, which is below the dura. They may need surgery or they may need an ICP or ventriculostomy to manage their ICP. Sometimes the bleed can be slower in these patients, especially in the elderly patient because of the atrophy of the brain. They have more space available. So if they start to bleed, there's more space to accompany the blood, and we might not see neurological change or perfusion deficits until a couple days later. Okay, so these patients may need surgery. They might need a craniotomy. They might need for us to go in and evacuate the blood. We might just need to do a ventriculostomy where we put the ICP in and we drain cerebral spinal fluid. It just depends on how quickly the subdural bleed comes on and how significant the neurological change is in the patient. And then we have intracerebral, which means it's not just below the dura, it's kind of through all the cerebral tissue. And this is usually within the brain. And we don't usually take them to surgery to evacuate the blood because it's too hard to evacuate. It's kind of intertwined between all the cerebral tissue. So if they do go to surgery, it's to do the craniotomy to remove the bone flap to decrease the ICP, but the priority in these patients is to manage the ICP. So if they have a ventriculostomy, can we drain off cerebral spinal fluid or blood? But if we can't, then we have to think about removing those bone flaps. And you guys shared yesterday in class about how you guys have had some patients that have been privileged to take care of and have had that, and they had their bone flap removed. Okay, so let me flip this bad boy here. Can finish this TBI here. Okay. So if we're thinking traumatic brain injury, we've just talked and classified all the types, right? So we talked about skull fracture, we've talked about concussion, a contusion, and then bleeding or hemorrhage or hematoma in the cranial vault. Okay. So don't forget about the diffuse axonal injury. That's like the boxing. That's the best analogy I can give you. And that's where they tear the axons. The axons are torn, the nerves are torn, so we can't repair those. There's a very poor outcome in these patients. Complications of a traumatic brain injury. Well, if we have bleeding and swelling in the brain, we have to worry about a shift and a herniation, right? So shift means you'll see the brain, the midline, and I don't know if anybody got to look at CAT scans this past week, but you'll see the brain will swell on one side and it'll shift one way or the other. And then it'll herniate against the brainstem. So the pressure becomes too high on one side of the brain, it shifts across midline, and then it herniates down. But that leads to brain death. Remember, we want to make sure that we decrease the CO2 so we can increase the respiratory rate to blow off the CO2. We have to monitor for infection if that dura is torn, or if we take them to surgery, we want to try to minimize the Valsalva maneuver. So we shouldn't be aggressively suctioning these patients unless they absolutely need it. We're not going in and suctioning every hour to 2 hours if the patients don't need it. Complications. So these are almost direct opposite of each other. So DI, we have a lack of antidiuretic hormone either being made or being produced. So what happens in these patients? They're peeing too much. Okay, they're peeing too much. The blood is dry. So I'm losing my water, but my blood is dry. So what happens? My sodium goes up because it's super concentrated. My serum osmo goes up and my urine specific gravity goes down. Okay, so my urine specific gravity goes down. It's less than 1.005. And these patients go into hypovolemic shock. They're dry. They're losing too much fluid. So what do we do to save them? Well, we give antidiuretic hormones. We can give vasopressin or DDAVP. We can give hypotonic fluids, lots of it. Boom. You guys remember me telling you the story about the guy that I had a self-inflicted gunshot wound? Given half normal saline, bag, right? I mean, he like lost 5 liters of fluid in just a few hours. And then of course, monitoring eyes and nose, really, really important that we're able to monitor eyes and nose. And we've got to think about making sure we maintain that cerebral perfusion pressure. So in these patients, they might have an elevated ICP, but the biggest problem we're going to see with these patients is they're going to have a drop in their MAP, right? Because they've lost volume. Then in the direct opposite, we have SIADH, and these patients have too much antidiuretic hormone. So now they're not peeing very much at all. We have too much antidiuretic hormone that's being released. They don't pee much. The blood is wet. So if the blood is wet and we have all this extra fluid, the sodium is down because it's diluted. The serum osmo is down because it's diluted, but the urine specific gravity goes up because we're not diuresing very much. Okay. So the urine specific gravity is 1.030 or greater. So how do I fix this person? Well, they have too much antidiuretic hormone, so I have to block it and give Vaprazole. Okay. Their sodium is low, so I can give hypertonic. We give it in very low doses. You guys were telling me that you had to give it in like 30, 40, 50 milliliter an hour increments. We put them on a fluid restriction. Okay, so we restrict their fluid. We can give some Lasix or diuretics, and then we monitor eyes and nose. Okay, how do we know these patients are better? You guys already know I love these types of questions. Now I've done this. I've recognized that my patients in DI or SIADH, I've provided these interventions. How do I know that my patients are better? Well, better when my eyes and nose improve. So if I'm in DI and I'm dumping 500 milliliters an hour, when I start to see that slow down, I know that I'm getting better. When my vitals stabilize, what's your patient's baseline? If my MAP now, because I'm in DI and I've lost so much, is 50 and it goes up to 60, I'm moving in the direction. But the most specific indicators, the urine specific gravity improves, it corrects. So if your urine specific gravity is 1.004 and now we're 1.010, good. Or if your urine specific gravity was 1.035 and now it's 1.022, way better, right? Don't forget, if we have all the swelling and the ICP continues to go up, we might need a craniotomy. We might need to put an ICP monitor in or a ventriculostomy to drain, and they can do a burr hole cranie. Okay, so the craniotomy is where they move the bone flap. Burr hole cranie is where they actually drill through the skull and they actually put the ICP in the patient through the burr hole. Meds for ICP, remember there's that handout I posted for you, but mannitol is your osmotic diuretic. That's going to decrease the swelling in the brain. Sedatives and paralytics actually decrease the stimulation to the brain. So those are very helpful. If we have damage in the brain or we have cells that are swollen in the brain, now we have to give anti-seizure meds, because if you've damaged the nerves are going to act funny, and that's when these patients have seizures. So I'm sure you guys that have done rotations in SIC have seen that we're given Keppra a lot, right? If you have any kind of traumatic brain injury or some kind of impairment to that cranial vault, a lot of times we're doing anti-seizure drugs to prevent that. We can give hypertonic saline. So if we have a lot of swelling, we give the 3%, which actually pulls the fluid into the vascular space and hopefully it's excreted. We can give barbiturates. Those actually help with seizure, prevent seizure activity. And then our neuromuscular blocking agents, we can do a neuromuscular blocking agent. And this is to paralyze the patient to decrease the stimulation. How are we doing? Questions? We okay? You want me to keep going?
I actually have a question.
Yeah.
So like, this sounds kind of dumb, but like herniation, does that just mean like compression?
Yeah.
On the brainstem?
So herniation means, okay. So if you think about a patients that, let's just talk about something different so we can like make this analogy. So if you think about somebody that has a umbilical hernia, what happens has anybody ever seen a patient or know somebody that has an umbilical hernia? Have you guys ever seen them?
It like sticks out of their belly button.
Yeah. So the bowel herniates through the muscle. It protrudes through the muscle. So when I think about herniation in the brain, if the pressure increases on one side and we have that shift in the ICP, so if you have these two sides of the brain, okay, and this side gets bigger, right? It starts bigger. It's going to shift over onto this side. And then what happens is the swelling becomes so great that it herniates and protrudes down onto that brainstem. So it's kind of pushes out of the cranial vault onto that brainstem, because your brainstem literally sits right at the base of that skull. So it kind of shifts and kind of protrudes down onto that brainstem. That's all that it means.
Okay, thanks.
Does it help understand it like visually a little bit better maybe?
Yeah, the word protrude helped me.
Yeah, kind of like protrudes down, it forces its way. It's just like the muscle would protrude out of the the bowel would protrude out into the muscle wall. This kind of protrudes like out of the cranium into that like the brainstem. It protrudes down onto the brainstem. Okay. Well, we'll go ahead and move. Any other questions, or otherwise we'll move on to stroke. Okay. So hemorrhagic stroke, I kind of put that right next to traumatic brain injury on your study guide because I feel like they're very similar. The cause is different, but the idea that the ICP and there's bleeding into the brain is the same. So if you look at hemorrhagic stroke, bleeding into the brain, what causes it? Well, in traumatic brain injury, they fell or had some kind of trauma, obviously. But in hemorrhagic stroke, they could have had an AV malformation that started to leak. They can have an aneurysm that burst. Patients that are higher risk are somebody that has consistently elevated blood pressure or smoking, elevated cholesterol. So I think if we talk about stroke, we need to think about our stroke scale. Higher you go on the stroke scale, the worse the patient is, right? And then, you know, the lower the score, the more the patient is stable. And then, so if we talk about signs and symptoms, it's same as traumatic brain injury. Neuro assessment is important. So I didn't rewrite all of that out. I want you to think about the signs and symptoms of change in level of consciousness, change in motor strength, change in pupils, change in vital signs, change in respiratory status, right? So don't forget to go back and think about that neurological assessment. Don't forget that a TIA is a warning sign for a stroke. So if your patient has neurological symptom changes and then it goes away, there's a 30% like chance that they're going to stroke again within that year. Okay. So FAST, this is our quick assessment for a stroke: face, arm, speech, time, right? We've got to act fast and we got to think fast. If you have somebody that has a left hemisphere stroke, right? So they're aphasic, agraphic, they have trouble writing and reading, they're slow, they're super precautious, they have no hearing problems, they have trouble with recognizing letters. Right side of the stroke, they're dangerous. I think right side dangerous, impulsive. They have these feelings of euphoria. They do have hearing problems. They have a lack of depth perception and change in sense of humor. So they're like, they laugh inappropriately sometimes. They're disoriented to face or to place and time. And then they often don't have facial recognition. So left, I think, super cautious and careful and slow. Right, impulsive and almost inappropriate. Okay. So if we have a hemorrhagic stroke, well, how do we know we have a hemorrhagic stroke? The patient comes in, we do the FAST. How do we know? The immediate thing that we have to do is we're doing our assessment, we do the stroke scale, but we got to get them the CAT scan. We have to differentiate if it's hemorrhagic, which they're bleeding, or ischemic. So these patients are going to have a non-contrast CT of the head, which is a very fast test. And if the test is negative, that means that they're not bleeding. So it's an ischemic stroke. If there is blood in the cranial vault, then we know that it's hemorrhagic. And remember, hemorrhagic is way less likely. It's like about 15% of patients have a hemorrhagic stroke, 85% are ischemic. Okay. But the treatments are completely different. So we have to know the difference. So if we have somebody that does have this CAT scan and it shows bleeding into the brain, and now we're looking for changes in the ICP, we know that this is like a traumatic brain injury. How do we treat these patients? Well, if we can get to the AV malformation, can we embolize it? Can we do like that radiation to it? If we have a aneurysm, can we clip it? This is the gamma knife radiation. Can we go in if we have an aneurysm? If we see that the patient maybe had a TIA, they had a neurological change, but then it went away. We see that they have an aneurysm. Can we go in and clip the aneurysm before they have a full-blown stroke? Or can we go in and put the coil in the aneurysm so the blood doesn't circulate through that weakened part of the blood vessel? If the bleeding becomes so great, do we need to treat them like a traumatic brain injury? Do we need to do a craniotomy? Do we need to do a burr hole cranie? Do we need to put in an ICP monitor or ventriculostomy? We need to look for signs of elevated ICP. We need to watch for aspiration, because these patients, if they have face, arm, speech, and time and weakness on one side of the body, are they having difficulty swallowing? So don't forget about the swallow test. We have to look for changes in vital signs. Remember, that's a late sign. We've got to look at our pupils. Change in level of consciousness, still number one. Do We have a unilateral weakness, so motor strength is equally important. We have to, if they're hemorrhagic, we have to worry about them bleeding again. If these patients very often will re-bleed within 24 to 72 hours, up to 2 weeks, most commonly 24 to 72 hours, but up to 2 weeks. So worry about re-bleeding. And then I already talked about the stroke after the stroke TIA. After they have a hemorrhagic stroke, we always are worried about the vasospasms, right? So we have to think about giving a calcium channel blocker, right? So Nimatop is our #1 calcium channel blocker that we use post-hemorrhagic stroke to prevent these vasospasms. So calcium channel blockers, we don't want the vessels spasming after the stroke. So we give the calcium channel blocker. It prevents the lining or the smooth muscle of the artery from constricting. We also want to use our 3 H's, right? We want to open up that vessel a little bit. So we make them hemodilute so that we dilute the blood. Okay, if we dilute the blood, it opens up the blood vessel. We make them a little bit hypertensive, right? We don't want them to have a blood pressure of 220 over 110, but a lot of these patients, we have a goal of a blood pressure of like 140 or 150 over 80 or 90. We make them a little bit hypertensive so that that vessel doesn't spasm down. And then hypervolemia, so we give volume to open up the blood vessel. So don't forget your risk factors. I talked about this. This is important to me. This is important to your patients, not just me. It's not about me, it's about them, right? So non-modifiable risk factors. What can't we change? But what can we change? Super important when we talk about cerebral vascular accidents and cardiovascular accidents. What can we help the patients change to improve their quality of life? Don't forget, before we feed them, we have to do a swallow test. Their NPO until they pass the swallow test. If you have them drink water out of a straw at the bedside and they start coughing, they stay NPO until they have a speech therapist come and do a full evaluation. Don't forget to check your cerebral perfusion pressure. If they have a ventriculostomy or an ICP, we still got to maintain that the same as we would if we had a traumatic brain injury. These patients have a lot of depression afterwards because their quality of life will change. And then our treatments, other than treating them, these vasospasms, our treatments are the same for an ICP or traumatic brain injury. So elevate the head of the bed, make sure they're in good body alignment, make sure that we don't have an increased intra-abdominal pressure, make sure that we don't have an increased intrathoracic pressure, make sure we don't have a high PEEP. We're not going to suction them or vagal or increase the ICP, right? We're going to make sure that we only suction as needed. We're going to hyperoxygenate and we're going to get rid of that CO2 before we suction them, right? So a lot of the treatments are going to be the same as a traumatic brain injury because essentially it is the same. It's just a problem with the blood vessel versus a trauma, okay? If we go back and we talk about ischemic stroke, okay, I want you to think about an MI, right? So when we talk about hemorrhagic stroke, we talk about like aneurysms or like an aneurysm giving way or traumatic brain injury. But ischemic stroke, I want you to think about that heart attack. It's the same thing. It's just happening in the brain. An embolus or a thrombus has blocked the blood flow to part of the brain. Just like with an MI, it would block the blood flow to part of the heart. Okay, so think MI, except it's part of the brain. Is it an embolus or thrombus? Embolus, we think AFib, something that came from the heart or somewhere else in the body and traveled to the brain. But a thrombus means that the plaque is just built up in that vessel and is now occluded off. Okay, so blocked artery. So treatments, okay, we can use this for I want you to think about like giving TPA. Okay, so if we have somebody that has swelling in the brain because of ischemic in the cells and we have an increased ICP, we need to think about that the same as a traumatic brain injury. However, if we have a patient that has a blocked artery, our priority for these patients is to give TPA. Okay, we've got to open up the blood vessels. So the priority in your patient that's an MI patient, we thought about going in and doing the balloon angioplasty and putting in a stent. But if you had somebody that, we not necessarily can't get to all the vessels in the brain, depending on the location. So we want to give that clot buster. Okay, so we've got to give that clot buster, that fibrinolytic. So if you have somebody that's going to get TPA, we need to look to see, did they have surgery recently? Have they recently had trauma, pregnancy? Do they have an elevated PTI and R? Their blood pressure must be less than 185 over 100. So 185 over 100. So if the blood pressure is up, we've got to give medication to control the blood pressure. So control the blood pressure. We can give Clevapet, Plevoprex or nicardipine. Nitro vasodilates. Hydralazine is an afterload reducer. It has it's an arterial vasodilator or labetalol. And remember, we're going to give all these IV. Okay. If we're going to give TPA, we have to do neuro checks after, right? So you have patients that is having a facial droop, trouble with speech, and muscle strength or weakness on one side of the body. So we give TPA and we see that neurological deficit correct, right? So now the neurological deficit is no longer a problem. So we see them get better. And then an hour to an hour and a half later, we see the patient's neurological symptom deteriorate. So now they start to have a change in level of consciousness. That's an emergency because now they might be having a hemorrhagic stroke. They went from an ischemic stroke to a hemorrhagic stroke because we gave the TPA. Okay. So neuro checks after TPA are your priority. We've got to make sure that the patient's now not bleeding. And then don't forget about bowel and bladder function. Okay. Are these patients able to urinate and they able to move their bowels? Okay. Now, one thing I did not mention, but I know it is on here. Oh, we talked about the Glasgow Coma Scale. Super important to me, right? Glasgow Coma Scale. And I know I have it on here somewhere because I remember looking this over. If we talk about the Glasgow Coma Scale, I don't know where it's at. Oh, here it is. Geez, I skipped right over it. And maybe I mentioned it, I already forgot. But 15, there's no change in level of consciousness. Less than 8 or equal to 8. Coma, we have to think about providing an airway. And then if they're 3, that's the lowest score. This is the worst that they could be. So the outcome's pretty poor there. So questions about traumatic brain injury or stroke, neuro assessment. Are we okay? Okay, let's go right into spinal cord then. Okay. So if you are the first person on the scene of a trauma and you're concerned that there's a spinal cord injury, okay, you are not going to move the patient. Okay. First on the scene, your priority is to make sure that the patient is not moved. We want to prevent secondary injuries. The primary is the injury that happened at the scene. So if they're playing sports, got hit in the head during a football game, and they're unable to move, that's the primary injury. Remember, if we have a traumatic brain injury, we should suspect that there's a spinal cord injury until we prove otherwise. The secondary injury is response to the primary injury, right? So now we have damage to the spinal cord. We have to think of it just like we would a traumatic brain injury. Do we have bleeding around the spinal cord? Is there something compressing the spinal cord? Is there swelling along the spinal cord? So secondary injuries to a traumatic brain injury or a spinal cord injury are always the priority for the critical care nurse. It's always the priority. Okay, so we think about hypoxia, swelling, ischemia to the spinal cord. Okay, this is the response to the primary injury. Reversibility, that's priority for the critical care nurse. Your priority is to reverse the secondary injuries or to stop. So you can have a complete spinal cord injury, which is paraplegic or tetraplegic. So that's just, this is kind of somewhere in the thoracic cavity or waist down. Tetraplegic is they're not able to move the upper extremities. It used to be called quadriplegic. You can have an incomplete spinal cord. So this is central, anterior, and lateral. So remember, central, it's like central cord. And this patients usually have motor and neurological deficits in the upper extremity. Anterior means that there's a damage to the anterior portion of the cord. And this is usually like a coup, counter coup, like a back forth type of injury. But with anterior, we have to be super careful about, it could also be a crushing injury. We have to, about the spinal artery. The anterior artery provides 60% of the blood flow to the spinal cord. And then we have lateral, which is a north-south injury. And we have to worry about, this is where they might have a motor loss on one side and like a pain and sensory loss on the opposite side. So central hyperextension flexion injury, motor and sensory function loss in the upper extremities. Okay. Anterior crush. So a lot of times these patients fall on top of their head or their sacrum fall, loss of pain, motor and sensory below the injury. We have to think about that spinal artery. And then lateral or Brown-Séquard, they have ipsilateral loss of paralysis. So touch, motor strength, pressure, vibration on the same side of the injury. So we think of loss of motor strength, contralateral loss of pain and temperature. This is a north to south injury. So knife type injury, like north to south type of injury. So how do we diagnose these patients? Well, we have to look at the x-ray. We can do a CAT scan, which is a very fast test. An MRI gives us a lot of information, but these patients have to be stable to be able to sit for an MRI, especially if we're doing the whole spinal cord. They have to lay flat for about an hour and a half. So we're looking for loss of function. And I gave you this example the other day when we were talking about this in the class, loss of function. We're looking for any sensory and motor loss, and even the smallest amount is significant and can warrant emergency surgery. So no cervical to lumbar loss of function. Remember, I said in class, you do not need to know it stop by stop, but I gave you some points I want you to follow, like know that cervical, we're thinking respiratory. Know that above T6, I've got to think about that autonomic nervous system. And the further you go down, the less impairment you're going to have whole body. So what are our treatments if we have a spinal cord injury? Well, we want to immobilize and avoid twisting and turning, right? We can use steroids. Sometimes it's controversial, but steroids are anti-inflammatory. So you have a lot of swelling in the cells around the spinal cord and it's compressing the cord. Maybe steroids would work. We have to think airway. If we're thinking cervical airway, do we need to provide backup ventilation? Have we severed part of the cord, or do we have a spinal shock above T6 where now we've impaired the cord? It's not permanent damage, but the nerves are not responding and now the muscles aren't working. So do we need to provide airway, oxygen? If we're talking about somewhere in the cervical spine, usually we have to think about doing a halo traction or halo vest. And this is the halo traction is like the tongs. If you remember, we talked about the tongs yesterday. That's where they have them inserted into the skull and then it goes to the pulley system. You never want to pull on the tongs. And then the halo vest, and I put, see the chart on the slide. I didn't rewrite all of this out, but you have to be thinking about that chart that's in there. I love that chart. It talks about like doing your neurological assessment, checking for skin breakdown every 2 hours, at least every 2 hours, making sure you're turning the patient every 2 hours, making sure that we have a wrench at the bedside. Are we doing pin care, whether they have tongs or they have the vest? Are we doing pin care, like making sure we're cleaning around the site, looking for signs and symptoms of infection, making sure we put nothing between the bars. We're not going to put a blanket or a pillow between the bars of a halo vest. Making sure we're doing neuro checks, right? We need to still make sure that we're not neurologically losing motor or sensory function, even once this halo or the tongs are put in place. Don't forget that if we have a collar, I have it highlighted here. If you have a cervical collar on, you have to be thinking about skin breakdown for that too. These patients wear cervical collars sometimes for 2 to 3 months. Do we have breakdown against the clavicle, right? Or underneath the jaw or the mandible? We have to be thinking about skin breakdown. So skin's really important when we think about these patients. Complications of spinal cord injury, right? So we don't forget about spinal shock and neurogenic shock and autonomic dysreflexia. So if you see how I have these pulled out together, spinal shock, and I have autonomic dysreflexia underneath spinal shock, because autonomic dysreflexia will occur after spinal shock. And then you have neurogenic shock. Okay, so there's a chart in the PowerPoint that you guys can look at again, where spinal shock usually occurs within the first 24 hours after the injury. It's temporary, but we have loss in motor sensory function below the level of the injury. So we have to be thinking about all those risk factors like DVT, immobility, contractures, skin breakdown, right? We might lose bowel and bladder function, but these patients typically will fully recover. Okay, sometimes it's weeks before they fully recover. Then you have neurogenic shock, and this is autonomic nervous system. So this is the system that regulates blood pressure, heart rate, temperature, right? These patients have an injury above T6 and they lose autonomic nervous system regulation. Okay, they have decreased blood pressure. So you'll see venous pooling. Okay, they'll have venous pooling and they lose their vasomotor tone. So you'll have venous pooling, fluid will leak out, their blood pressure will drop, they will be unable to perspirate, the skin is warm and dry. Okay, so if I have somebody in neurogenic shock, I'm thinking vitals, right? Are you guys thinking vitals? We've got to make sure that we give them maybe neosynephrine or norepinephrine. We can give them atropine, right, to bring up the heart rate. We've got to control that shock because the blood vessels go wide open. It's distributive shock. So maybe we have to give fluid, maybe we have to give a vasopressor. If we give the vasopressor, do we need to give an inotropic agent to help bring up the heart rate and to improve contractility? Then we lastly have autonomic dysreflexia, right? So this occurs after spinal shock resolves. Okay, it's not related to neurogenic shock at all. It happens in injuries above T6, and we have an exaggerated autonomic nervous system. So these patients usually are sweating. Remember, here in neurogenic shock, we have no perspiration because we lose our autonomic nervous system regulation. But in these patients, the blood pressure goes up. Sometimes the heart rate goes down. They'll have a severe headache. They'll start profusely sweating, and it's usually related to some kind of stimulation below the belt. So we always have to think about bowel, bladder, and skin, okay? The priority for these patients is to sit them up right away, fix the problem, and then vasodilate, okay? So we're gonna sit them up first, then we've got to think about how do we get that blood pressure under control and then fix our problem, okay? So then we can say, is it urine, which is most common? Do we need to put in a Foley catheter? Do we need to straight cath them? Are they constipated? Do we need to, evacuate stool from the bowel? Okay. And a lot of times with these patients, if we do have to evacuate stool from the bowel, sometimes we have to numb that bowel area, because if you're trying to evacuate, it actually causes more stimulation. So sometimes you might see us use like some kind of lidocaine gel or something before we evacuate the stool. And then don't forget these things that are just automatically in your mind, but don't forget about preventing DVTs. Don't forget about skin breakdown. Don't forget about range of motion. Don't forget about aspiration and breathing, nutrition. These patients can develop foot drop and they can become depressed depending on how their quality of life is going to be and what their damage is. Is it permanent? Is it temporary? Right? We have to think about all those things. I also drew out this picture for you guys. This is kind of back towards stroke. But I was hoping this would help you visualize the homonymous hemaniopsia, right? So remember, we talked about homonymous hemaniopsia, and you need to know this concept, okay? So this is why this happens. So let's say you have a clot. Remember, homonymous hemaniopsia is you have the vision change, and they throw a clot usually from the carotid artery, okay? So they throw a clot that affects the eyes. So you have this clot. Okay, it comes into the right artery, feeding the eyes, so they can't see to the right. So this is why this happens, is this clot occludes. Now, this is like us looking on top of the head. So you're like looking down right here. Okay, we're looking down, and this would be looking at the patient's eyes, like going out in front. So if this clot happens on the right side, and they have right-sided homonymous hemaniopsia, okay, this occludes the blood flow to the right side of the right eye and to the right side of the left eye. So the vision loss is going to be on the right side of the left eye and the right side of the right eye. Okay, so this is right-sided homonymous hemaniopsia. So if you wanted to see what this was like, then you would cover up the right side of your right eye and the right side of your left eye. Okay, and if you would look straight ahead, can you see straight ahead? Yeah. If you look to the left, can you see to the left? Yes. If you look to the right, can you see to the right? No. Okay, so you have to think about quality of life and daily living for the patient, right? So they could not visually see to the right. So we would avoid giving them items on the right side. We would avoid putting objects on the right side, right? We wouldn't put their hot cup of coffee on the right side of their tray, right? If we were going to give it to him, let's think of it in the opposite sense. So if I would say to you, where are you going to give your patient that? You're not going to hand them their pills and put them on the right side of the tray, but you would put them on the left side of the tray, right? And then of course it would be exact opposite if you had left-sided homonymous hemaniopsia. If it was left-sided, you would have a clot being thrown to this left coronary, or not coronary artery, artery to the eye, for lack of better terms currently. And then, so what would happen? You would lose blood flow to the left side of the left eye. You would lose blood flow to the left side of the right eye, and you would not be able to see to the left. So you would go ahead and put your hand on the left side of the right eye and the left side of the left eye. And can you see straight ahead? Yes. Can you see to the right? Yes. Can you see to the left? No. So in that case, you would avoid putting stuff to the left or the 9 o'clock position, or you would set it at the 3 o'clock or the right side of the patient, because that's where they would be able to see. So that's how I want you to think about that, because that's how we maintain safety with these patients. Questions?